I'm at home.
Um,
And it keeps saying Chrome recommended, and I already have Chrome.
Yeah, he's having trouble logging in, so.
Yeah. We have a minute more, but we are live all the same, but we have just a minute more, so.
Okay.
Right, Prof, are we ready to go, or do you think we should give him a few more minutes?
So what do I do now?
Yeah, can you let him in?
He's not in yet. He's not in the studio yet.
Yeah, so entering, just click enter studio.
You have to walk me through this. The browser has blocked your mic and camera.
Oh, so I think you may have to enable the mic and camera. Let me see.
Good evening, viewers. Thank you for joining us once again for tonight's edition of Wisdom Conference Time with the Doctors. We are experiencing a bit of a technical issue, so if you could just bear with us for 5 minutes, please. I know we are live, but if you could just bear with us for 5 minutes, we will set the ball rolling. Thank you.
Hi.
Hello.
All right. Sorry about that. I thought it was going to be as smooth and as easy as Zoom.
All right. So thank you, viewers, for waiting on us. We had a little technical challenge, but once again, we come to you with the time with the doctors. And today we have a very interesting topic to discuss. We're going to discuss lung disease. And with us today, we have Dr. James Apia Pipim, who is a pulmonary and critical care doctor who specializes in lung diseases as well as conditions that require intensive care. And he is in Augusta, Georgia. He has been a doctor for a long time, and um, he and I kind of met about 20 years ago in Connecticut. And he is very experienced and he will be helping us answer the questions. And secondly, we have Dr. Daphne McBruce, who is also a pulmonary and critical care doctor, just like Dr. Pippin. She is based in Fort Smith, Arkansas, and she's also experienced in diseases of the lungs and conditions that require intensive care, intensive care treatment. And so both of them are going to be very good in answering our questions, and hopefully we will learn a lot. So whilst we go through this, if you have questions, just post them in the chat and share the links so that your friends and family can listen and learn something. I'm going to hand over to my able co-host, Maud, to continue.
Right. Thank you very much, Prof. Lai. It's always lovely to be here with the doctors, and it's such a privilege once again. Now, tonight, just as my able professor has already set us off, we are going to be looking at lung disease. And I'm sure you may be wondering of what significance is this, and that's why we are very privileged to have all these professionals here to talk us through. So, Dr. Pippin, my first question comes to you. And the question is, what are lungs and what are their functions? What's the functions of the lungs and what are the lungs itself? Thank you.
All right. So before I get started, can you guys hear me?
Yes.
Okay. So before I get started, I'd like to say a big thank you to the group for inviting me and Daphne to come talk about lung diseases. Obviously, that's an area we're both very passionate about. That's why we're in the specialty. So we're going to do our very best to try and break it down into things that are easy to understand and hopefully follow. And please, we will be honored to try and answer any questions that remain after we explain things. So to kick us off, the lungs are what we use to breathe. So simply put, in order for us to live, we need to have our lungs working normally. And the reason for that is oxygen in the air that we breathe goes through our lungs into our blood. And by so doing, it provides the fuel for our bodies to function. So if we don't have the fuel to function with, then we could run into trouble in terms of living and being able to do the things that we love doing, all of the activities that we love doing. To put things in perspective, when the lungs are opened and spread out, they actually occupy the space of half a tennis court. So even though they are compressed into our chests, our lungs actually, the surface area of our lungs is actually the size of half a tennis court. That's 70 square meters. That's what the lung tissue is there for. And it is supposed to be thin to allow gas to go across it easily into our blood and then subsequently into the rest of the body. So lungs are very, very important in terms of what we need to live. And I will add a preface here, Psalm 139, verse 14, we are truly, fearfully, and wonderfully made.
Thank you so much. That was a great introduction to what the lungs are. You know, so you mentioned that the lungs are what helps us to breathe, but I think the average person on the street knows that, oh, it's the nose that helps them to breathe. And then some people have heard about the respiratory tract. So what's the difference between the lungs and the respiratory tract?
Okay, so that's an excellent question. In order for air to get to the lungs, it has to pass through a series of tubes. And it starts from the nose, it goes through the throat, it goes through other breathing tubes to get to the lungs. So we have all these pipes that start from the nose and the mouth and end up in the lungs before the gas that you have breathed in is able to get into your bloodstream. So the big difference is that all of those passages plus the lungs make up the respiratory tract. The lungs are part of that respiratory tract, but it needs those tubes to conduct or to get the air to the lungs for that important function of oxygen getting in and carbon dioxide coming out to happen.
Fantastic. Thank you very much, Dr. Pippin. Viewers, could you please tell us where you're watching from? I can see Bishop Johnny Isaacs from South Africa. I know Pastor Kofi is watching from Ghana. Could you tell us where you're watching from? And please share this educative video with your family and friends. There's so much to learn. So please do share this video. Dr. McBruce, so my next question comes to you. What are some of the common lung diseases that we have? So I mean, growing up, I've heard so much about asthma. I know a little bit about COPD and then cancer. So what are some of the common lung diseases that we have?
Well, thank you so much for having me. Thank you for the invite. I'm really happy to be here. As Dr. Pimpin said, we're obviously very excited about our field, so we love to talk about it. And so if we do go off on a tangent sometimes, it's just from passion, and you can reel us back in. As you've mentioned asthma, you've mentioned COPD. Those are pretty common lung diseases across the world. And we have infections that can affect the lungs, like pneumonia and TB, which, I mean, obviously every one of us has at least seen somebody who's had pneumonia or TB at some point. Then you also mentioned lung cancer, which is also, unfortunately, the most common cancer, especially in the United States right now. And so affects a lot of people, which, you know, so those are some of the most common lung diseases. But basically, infections are really starting from the upper respiratory tract, which is the upper airways, the pipes that Dr. Pimpin mentioned. So bronchitis is also pretty common.
Thank you so much. So hopefully we will go into some of the conditions that Dr. McBruce has mentioned. I'm coming back to you, Dr. Pippin. So, you know, when we talk about the lungs and problems to do with the lungs, we always hear about smoking. So what is the effect of smoking on the lungs? And as you talk about that, if you can also talk about like secondhand smoking and what it is and whether that has the same effect as somebody smoking.
Okay, so there are obviously a number of things that smoking can do to the lungs, but I will start off by saying the lungs were not supposed to serve as filters, which is what happens when we try and smoke, because we are asking the lungs to do something that they were not created to do. So in the process of smoking, what you end up doing is the lung tissue is scarred, meaning it is damaged by smoking. The scarring is similar to a sore in the lung tubes and in the lung air sacs themselves. And so that can cause sometimes swelling, and it can cause our bodies to produce a lot of phlegm in order to defend it against all of this scarring and some of the damage that smoking can cause to the lungs. So the big things are that because the airway is scarred or the airway is damaged, you end up with irritation of your airway. And as you would observe, many people who smoke cough because their airways are irritated by the effect of smoking on the lining of the tubes through which we breathe. But not only that, it also causes swelling. And that swelling can sometimes give us the diseases that we mentioned already, like asthma and COPD. And then on top of that, it decreases our ability to fight any kind of infections. And so people who smoke tend to get a lot of infections frequently. And then the last thing is it decreases our ability to fight cancer-causing chemicals because it weakens our immunity or our ability to defend ourselves. And so instead of the lung getting rid of some of these chemicals, these chemicals settle in the lungs, they cause our cells or the lung cells to start multiplying the wrong way. And then it can sometimes lead to lung cancer. So every illness that you can think about with respect to the lung, whether it's asthma, it can worsen asthma, whether it's COPD or chronic bronchitis, it can cause that and worsen that. Whether it is lung cancer, it can cause that. And then with pneumonias, it can increase your likelihood of developing a pneumonia. So cigarette smoking is bad for the lungs, and it's principally because the lungs were never meant to act as a filter to get rid of all of those chemicals. And by the way, there are 7,000 chemicals contained in cigarette smoke. So any one of those chemicals can cause you damage, and dealing with 7,000 of them really decreases your chances of winning that fight against cigarette smoke. Now, in terms of secondhand smoke, it is probably not as dangerous, but it has the same effects in someone who breathes a lot of secondhand smoke. So there are cancers that are seen in non-smokers that are principally due to their exposure to secondhand smoke. There are many more asthma episodes in kids who live in households where their parents or somebody in the household smokes. So it can cause the same irritation. It's not coming directly from the individual inhaling the chemicals, but they're still exposed to it because they breathe in those chemicals, and it can have the same effects as primary smoking.
Right. Thank you very much, Dr. Pippin. Can I say hello to Nakua from UK, who is watching, and hello, Pastor Martin Karimi from Kenya. Thank you for joining us. Viewers, could you please continue to share this with your family and friends, please? Right, Dr. Pippin. So you were talking about smoking and the effects of smoking on the lungs. Now, what about vaping then? Because it's just so common, and especially among the teenagers. Mm-hmm. So a few weeks ago, I was talking to a group of teenagers, and they were telling me that, right, do you know that some of our classmates actually vape? And I was like, oh, really? And so what are the effects of vaping then on the lungs?
All right. So vaping was supposed to be a safer alternative to smoking, but more and more studies are showing that vaping is not as safe, and it's probably not the best way to stop smoking, because there are much, much safer ways to stop smoking. One of the things that I tell my patients who vape, and especially who have youngsters who vape, is that this is the new way of hooking teenagers onto nicotine, because vaping products actually contain nicotine. So it's all these devices that look like cigarettes, that have a lot of chemicals in there that allow you to inhale these chemicals and then blow out smoke that is similar to cigarette smoke without holding a cigarette. Unfortunately, many of these chemicals, though, have similar effects to what is already in cigarette smoke. And so you are not avoiding exposure to these chemicals. You're just using a different device that is not cigarettes. Yes, it is less harmful, but like I said, there are much more effective ways, like taking medicines or using nicotine replacement products that can be safer than use of these vaping products. And they can look like ordinary pens. I mean, some of them look like USB ports. So they can be very deceptively carried around without you even knowing what exactly is being carried around. But again, the products in there contain many of the chemicals in cigarette smoke, and we are hooking a new generation onto nicotine inadvertently, because nicotine is contained in many of these products. Last thing, there have been a few reports, and actually increasing number of reports, of severe lung injury that has happened in people who have vaped. there's actually a new condition called E-Valley. And E-Valley just is e-cigarette and vaping product associated lung injury. It is to all the world just as severe COVID pneumonia. So this is not something to be played around with. And kids have been known to develop this, and people who use vaping products have been known to develop this. So it's really, really important that we keep kids from getting hooked, number one. And two, for those adults who want to quit, give them safer ways to do so without adding something that is not going to be extremely safe.
Thank you so much. So it looks as if, cigarette or smoking or tobacco is very addictive. And so any way of trying to use any tobacco-based product is going to be addictive, and it sounds like that's what's happening to those who are using these vaping products.
That's correct.
So I'm going to move to Dr. McBruce. So, when I teach medical students, one of the things that I talk about is that smoking is the worst thing man invented. I hope you guys agree with me, but it's something that I always tell my students, that a lot of the diseases that we have in the world would not be a problem if it weren't for smoking. So Dr. Pippin mentioned that smoking can cause lung cancer. What is the risk of that? That is it like everyone who smokes gets cancer, or is it only a few people who smoke who get cancer, or does everyone who smoke get lung cancer?
So that's an interesting question, and it goes back, Dr. Pippin talked about how smoking primes your lungs for different illnesses. And really, there's a lot of carcinogens in cigarette smoke. So all these chemicals that you're exposed to can set up really at a cellular level an inflammatory reaction. And so the cells actually change. And if you're not able to contain that change, then it can lead to lung cancer. So the answer to your question is simply that if somebody smokes, they're at higher risk for cancer, but not everybody who smokes ends up with lung cancer. The thing that we forget a lot is that lung cancer is not the only problem with cigarette smoking. So there's a lot of other cancers that are also associated with cigarette smoking, which, that's not the primary focus of what we're talking about today. But cigarette smoking is, for a lung doctor, the primary worst thing that you can ever do. The other thing about the carcinogens that are in cigarette smoke are also vape pens. So vape pens and cigarette smoke and secondhand smoke all prime you for lung cancer and put your risk for lung cancer at a really high risk. Now, having a family history of lung cancer also puts you at a higher risk, and the older you get, you have a risk for lung cancer as well. The longer you smoke for, then that risk is there. But a lot of my patients come to me and they say, but I stopped smoking 20, 30 years ago. And I say, well, the damage started right from your first cigarette, so that you can't just say, oh, I smoked only for 10 years, or I only smoked half a pack I only smoked socially for. That's one of the ones I get a lot, is that I only smoked socially. I only smoked when I went out to eat. And then something that people don't take into consideration is cigars. People feel that cigars are generally safer, but they also put you at risk for lung cancer. So, as a lung doctor, cigarette smoking is the absolute worst thing.
Thank you, Dr. McBruce. Since you are talking so much about lung cancer, I think maybe we should know the symptoms of lung cancer. So could you just talk us through the symptoms of lung cancer, please? Thank you.
Yes. So, yes, we talk about lung cancer a lot because, lung cancer is the most common cancer and the most common cause of cancer death, particularly in the US. And really, as with all cancers, it starts off as a primary cell that's quote unquote mutated, changed from what it was supposed to be like. And now the cell doesn't behave like it's supposed to behave, and then it grows abnormally. Unfortunately, especially with lung cancer, when it starts off, there are no symptoms. And as it gets worse, as it gets bigger, or as it starts to move from where it started and then it moves to other parts of the body, then you can get some symptoms. So some of the symptoms you will get later in lung cancer would be shortness of breath, cough. Very rarely you will get people who are coughing up blood, especially if the cancer goes into your breathing tubes. But like I said, these are like when you're in like the late stages, like stage 3 or stage 4 of lung cancer. Really, right now, the recommendation is if you've smoked within the last 15 years and you're older than the age of 50, then you should get lung cancer screening, which is a low dose CT at least once a year. So, the symptoms, like I said, are very similar to a lot of other illnesses like coughing, shortness of breath. It's very similar to COPD and to everything else, and they're very late in the presentation. So you don't really have symptoms early on, and the best way to find out is to get screening.
So, so coming back to you, Dr. McBruce. So, we're talking about lung cancer that is developing primarily in the lung. Can you just mention a little bit about other cancers that spread to the lungs? Because we know that sometimes people with breast cancer will have it spread to the lungs. People with colon cancer sometimes can spread to the lung, and other cancers from other places that can spread to the lungs. What's the difference? And then as you talk about it, can you talk about how it is treated, how lung cancer is treated in general, and whether the primary lung cancer is treated separately or differently than the other cancers that spread to the lung?
So basically, your entire blood volume, your entire blood volume goes through your lungs, so almost any cancer can spread to the lungs. The most common cancers that spread to the lungs are the two that you mentioned: colon cancer, breast cancer. But really, any cancer can spread to the lungs. There are also other types of cancers that present in the lungs, like lymphoma can present in the lungs before they present anywhere else. I've had patients who have had hepatocellular carcinoma, which have spread to the lungs. So basically, almost all the cancers can spread to the lungs, the most common being breast and colon. The way that you treat a cancer that has spread to the lung is different from the way that you treat a primary lung cancer. So as lung doctors, we want, for somebody who has a primary lung cancer, the most curative of all the treatment options that we have would be a surgical option where they will take out that part of the lung where the cancer is residing. And that, for the most part, can prolong your life. When surgery is not an option for whatever reason, that could be because you're not strong enough to go to surgery, or because you have too much lung damage, so that if we take some part of your lung out, you won't be able to breathe. So when surgery is not an option, then sometimes we do some different types of radiation as an option. But most of the time, cancers present late. And so if we're not able to catch it early enough, then they will do a combination of chemotherapy, which is to give you a chemical that will destroy the cancer, radiation, and then immunotherapy, where we use your own immune system. We give you a chemical that will stimulate your own immune system to destroy the cancer. If it's a cancer that started somewhere else in the body and then moved to the lung, occasionally, if you only have one metastasis, then we can explore surgical options. But most of the time, then it would be based on the type of chemotherapy that you would give for that primary cancer. So if it's primary breast, then they would treat it like a breast cancer that's metastasized, versus like the treatment that you would give for a primary lung cancer to begin with.
Right. Thank you very much, Dr. McBruce. Dr. Pippin, my next question comes to you. What is asthma? What is asthma? You're muted.
Yeah, I think he's mute.
Yeah.
Go for it.
All right. Okay. So yes, so asthma is a condition that affects the breathing tubes, and it can affect the smaller breathing tubes just before you get to those air sacs that we use to breathe, but it can affect a slightly higher group of breathing tubes. And what happens with asthma is it is not always present. Typically, people who are not having an asthma attack do reasonably well and don't feel unwell. When they do get exposed to things that bring their asthma on, and I'll talk about a few of those things, then those breathing tubes swell up, they narrow down, and what ends up happening is they have difficulty breathing, and you hear a whistling sound that we call wheezing when they breathe because those tubes are swollen and narrow. And when you're trying to pass air through narrow tubes, it is much more difficult for the individual to move that air in and especially out of their lungs because the tubes are narrow. So, what causes asthma? There's still a lot of research going on with respect to why people or why some people develop asthma. But there are four main things that have been postulated to have the biggest influence on why people develop asthma. Number one is respiratory infections as a child. So if you had a lot of colds and a lot of viral infections as a child, that could predispose to you developing asthma later on in life or even in childhood. Second is allergies. And people are allergic to a number of things, but the big ones are dust mite, to pet fur, to things like in the workplace, there may be chemicals in the workplace that they are allergic to. Some people are allergic to certain medications. Some even with exercise, it tends to cause their breathing tubes to narrow up. And there have been a few celebrated sports athletes who were asthmatic, who actually went on to achieve a lot of good, like Florence Griffith Joyner was supposedly an asthmatic, even though she was at one time a world record holder. But exercise can narrow your breathing tubes and bring on asthma that otherwise is well controlled in these individuals. So then there's genetics. That's the third one. Typically, if you have a parent who has asthma, you are more likely than someone whose parents did not have asthma to develop asthma. So that's the genetic part. So there is respiratory infections, there's allergies, there's genetics, and then the environment. The environment includes things like secondhand smoke. If you don't smoke as a child, but are exposed to a lot of secondhand smoke, that could bring on asthmatic symptoms in that individual or worsen pre-existing asthmatic symptoms in that individual. So in essence, it's narrowing those tubes that are otherwise open to allow air to move easily in and out of those tubes, and having those tubes narrowed, making your work, making it more difficult to breathe, and causing you to have chest tightness and a wheezing sound when you try and breathe out of your lungs. That is essentially what asthma is.
So continuing on asthma, so how common is it? And is it more common in certain parts of the world, or is it just a disease of rich countries or poor countries? Or
okay, so this is one of the few conditions that tends to be more prevalent in the developed world. And there are reasons for why the developed world has more asthma. One of them is obesity. Increasing weight has been associated with the development of asthma. But there are other things, just urbanization, meaning development actually causes you to be exposed to more air pollutants, okay? With all of the cars that we have, many more cars than we have human beings, that all of that air pollution has been postulated as one of the things that actually brings on a higher incidence of asthma. In fact, the top 5 countries in the world with the highest rates of asthma are Australia, Sweden, the United Kingdom, Netherlands, and Brazil. And all of them, except for maybe Brazil, which is an upcoming development, but it's certainly an urbanized area, tends to be those are the countries that actually have the highest asthma rate. And it's principally because of obesity, air pollution, and urbanization in those areas.
Right. So I was just, since I'm in the UK, I'm just even more intrigued and more interested. And I was just going to ask you, what are the risk factors, which I know you've spoken about some of them, but yes, could you just reiterate what the risk factors are, please?
Okay. So the 4 big ones are respiratory infections during childhood. That's probably the biggest one. If you get a lot of these infections, your tubes start to get scarred at an early age. They don't get repaired completely or properly. And as a result of that, later on in life, when you're exposed to some of these same chemicals, your tubes are not in the best shape, and therefore the narrowing and damage that has occurred allows them to more easily narrow up. So respiratory infections, biggest one. Allergens will be the second. And then genetics. You were born into a family that had a parent, a mother or father who had asthma, and the genetics we don't fully understand, but it tends to be higher in those whose parents have asthma. And then the last one is other environmental exposures. And I would add obesity and increasing weight has become a very big risk factor for development of asthma. In fact, I have a colleague, a former colleague, whose main focus of research right now is trying to identify the exact links between obese individuals and the higher rates of asthma. And he's discovered a few chemicals, something called adiponectin, that is higher in individuals who are obese, that tends to contribute to the narrowing of the airways that happens in asthma. So people are trying to come up with explanations that would allow us to make medications to try and address some of these links that they're coming up with. But clearly, some of these things are more prevalent in developed countries, and it is part of why asthma is more common here to begin with.
So, Dr. Pippin, are there different types of asthma? You mentioned that, some people is through exercise and stuff like that. Are there different types, or is it all the same?
Okay, so there are many different ways to classify asthma, but I would say the most common one that I use and many people use is the following. So number one is the allergic type. People who, when they are exposed to pets, pollen, perfume, dust, tend to develop their asthma. And then there's the non-allergic type, typically medications, and some common medications, such as aspirin, can actually bring on asthma attacks. Ibuprofen can bring on asthma attacks. People who have fast heart rates and get given beta blockers, atenolol, sometimes for blood pressure, but sometimes for fast heart rates, all of those drugs actually can predispose people to developing asthma. And then there are 2 special types. One is cough variant asthma, where these individuals just cough. They don't develop they develop asthma symptoms, but the main symptom that they have is coughing, and it can be coughing in the day, coughing in the night. And so they have to be investigated for the possibility of having asthma. And then there's those who have asthma only at night. And it makes sense because, like every other part of our body, our lungs go to rest at night. That's what we're supposed to be doing, okay? And so all of our muscles relax at night. And so if you already have narrowing that is present, then at night it's more likely to be magnified, simply because, all your muscles are relaxed, and therefore your breathing muscles are also relaxed, and you can't move air as much as you should be able to. And then the 2 last types are the exercise-related ones, typically cold air. All right. And people who have exercise-induced, what we call bronchoconstriction, will develop narrowing when they are exposed to cold, dry air, because it serves as an irritant to their airways. And then the last type is specifically seen in adults who develop asthma, who didn't have asthma as children. When they come to you for the first time, adults who have asthma, my first question is, what job do you do? Because typically it is due to exposures in the workplace. If they never had asthma before and they're coming to you as a 30-year-old or 40-year-old, suddenly start having asthma, you always have to look into what job they do, because it works like magic. We tell these patients, keep a diary of your symptoms, and we typically give them a device to blow into. It's called a peak flow meter. They do it twice. And essentially our goal here is we say do it for 2 weeks at work, and we ask for permission to be away from work for 1 week. So we can document what happens when they are at work. Their tubes are narrow. They go off work for a week or even a weekend, and suddenly their breathing is much better. You can draw a direct line from what they do at work and the exposures there to how they are feeling and why they have asthma. So that's one of the things that we're seeing more and more of, because as we all know, we have more and more chemicals and more products being made. And many of these products haven't been tested long enough to figure out all of their adverse effects. And sometimes the adverse effect could be asthma or causing asthma in someone who works in that particular workplace.
So let me just do a follow-up on that.
Mm-hmm.
So I remember, a long time ago as a teenager, my dad telling me that he had been diagnosed with cardiac asthma. I remember it very well, at the time. Is that also part of asthma? And then also, there are people who have acid reflux and have kind of asthma-like symptoms. Is that also kind of part of asthma that we're talking about?
Those are excellent questions. So first of all, one of the teachings that we all got in our pulmonary training was that not all that wheezes is asthma. So what that means is, yes, asthmatics wheeze, but so do people who have fluid in their lungs from cardiac problems. So do people who aspirate, like people who have reflux. So do people who have COPD. So you have to delve deeper into what is causing the wheezing, but there is a condition known as cardiac asthma that is related to the heart. That is not the typical lung asthma that we're talking about in this particular instance. So it is an accurate diagnosis, but it was likely coming from his heart, not so much from his lungs swelling up, narrowing up, and causing the typical asthma symptoms. With respect to reflux, that is one of the biggest triggers for people's asthma attacks. With the increasing, again, obesity epidemic, we have more and more people developing reflux symptoms, and anything that goes from your throat into your breathing tubes can irritate your breathing tubes and cause you to have an asthmatic attack. And so that's also one of the things that we delve deeper into when we see asthmatics, to make sure we've identified what the true trigger is. Because if we don't treat that, they just keep coming back to us. So we need to figure out, is your trigger your reflux? Is your trigger exercise? Is your trigger a medicine that you're taking? Whatever your trigger is, we need to identify those triggers, modify them, and see if we can control the asthma states better.
Wow. Thank you so much, Dr. Pippin. I actually had a question about an adult being diagnosed with asthma because, my aunt, she never had asthma. And then suddenly, when she was in her 30s, she was diagnosed with asthma. So I was going to ask, is that possible? And
yes.
Which you've rightly answered. So thank you very much for that. Now, moving on, I'm just thinking, how serious is asthma? In the educational setting, you see so many children who have asthma and they come in with their inhalers, and they just have this feeling, and then they tell you, I really need my pump now, I really need my. And so how serious is it, and how serious should we be paying attention to people with asthma then?
So it can be serious. Fortunately, though, we have fairly good medications that we can use to prevent serious attacks of asthma. And what do I mean by that? People typically have early symptoms of asthma. Asthma doesn't suddenly come up on you. Typically, most people in whom asthma suddenly comes up on have ignored their earlier symptoms. That is typical of, they get used to it. And so unless it's really bad, they kind of think, oh, you know what, it will get better, and I just need a few pumps here and there. And some may even not use their medicines as they're supposed to. So a big part of what we do when we see asthmatics is we always take the opportunity to educate them about the importance of what we call maintenance medications. These are medicines that they should use every day, whether they feel well or don't feel well. And the reason for doing that is so that they can keep those breathing tubes happy, open at all times, rather than wait for a crisis to try and keep them open, because it then is an emergency rather than something that you just have to work a little bit more on to improve. So we always want to make sure that they know that these medicines may not be fun, but those are the medicines that will keep them doing relatively well, so that if they do have a crisis, they can reach for those quick acting medications and not run into as many problems because their breathing tubes are not as narrow and their asthma is not as bad. Oftentimes, the groups that we deal with that tend to come in with more severe asthma and sometimes get hospitalized and sometimes even die from their asthma are individuals who unfortunately come from our minority communities, who don't have as good access to healthcare, who are not as educated on their disease and how to keep it in check, and oftentimes present very late in the sequence of events. They come in when, it is really serious, and sometimes they need breathing tubes, they need multiple treatments to try and open up the airways. And sometimes we're able to help them, but at other times it results in them not surviving. Fortunately, in spite of everything that I've said, in the US, and I'm not minimizing the number in any way, compared to something like COPD that has 120,000 deaths every year in the US, asthma causes less than 4,000 deaths in the US every year. So it can be easily and well controlled, and we haven't had as many problems with asthma as we have had with many other diseases. But the important thing is to make sure people take their medicines appropriately when they're feeling well, so that when they start feeling sick or they have an infection or something else is going on, you can do a lot less work to get them back to breathing as well as they can, as opposed to not taking their medicines, kind of not doing well. Their breathing tubes are narrower. Now they get an infection on top of that, and then all hell breaks loose, because it is a much more serious thing when they present like that.
So before we move on to Dr. McBruce, there's a question about. So somebody says, can you elaborate on people who have wheezing and asthma-like symptoms when they get panic attacks?
Yes. So excellent question. And why I didn't mention it in the beginning was that the severe emotions in some individuals can trigger their asthma attacks. It's not a very common thing, but people who are really distressed may suddenly start wheezing, be short of breath. And again, it is part of the trigger for that particular individual, and it is not the same for every individual. People have different triggers. So it may be dust, it may be perfume, it may be pets, it may be reflux. There are some whose trigger is severe emotions, and we are aware of that. And oftentimes the key thing is to make sure that if they are.
Okay, thank you. So, Dr. McBruce, so we've talked a lot about asthma. So, how is it treated?
I guess Dr. Pimpin sort of mentioned some of these treatments. Always the treatment goes back to what starts the asthma to begin with. And as Dr. Pimpin has explained so well, asthma is really a problem of your bronchial tubes, which are these airways, getting swollen. And so the hallmark of treatment is to try to decrease that swelling or try to prevent the swelling to begin with. Now, on top of like trying to maintain the tubes from swelling to begin with, then you also have triggers that can make everything worse, and you want to treat the triggers as well. So obviously the most important thing is to try to avoid the triggers as much as possible. And unfortunately for asthmatics, like Dr. Pimpin has gone on about, the triggers can really be just about anything. And some of these triggers are really unavoidable. So for example, weather changes can actually trigger asthma. So in patients who have really bad asthma, then the triggers could be something as simple as a higher pressure or more humidity or very cold air. And so if you can avoid really cold air or really big changes in humidity, for example, if you're driving to work, use your AC, don't try to drive in the heat. That's just, pretty basic, trying to avoid the triggers. The other thing that can be a really big trigger, like Dr. Pimpin said, was pollen and a lot of environmental factors. So if you can improve the air quality, either at work or at home, then you can try to keep your asthma in check. So improving air quality would be to use better filters in your heating system, for example. And I usually recommend that my patients use the highest grade that their equipment will tolerate. So not every equipment will tolerate the highest grade, like the big purple filters. But if your equipment would prefer you to have an orange filter, then try to do it. And then even more important than using the highest grade filters, to change your filters frequently. So they recommend changing your filters like every 3 months. And for some of my asthmatics who are really bad, they change their filters every month. And then because, pet dander can trigger asthma, I prefer for my patients to have non-carpeted floors. So any hardwood floors are better than carpeted floors, and try to avoid carpet as much as possible, because carpet traps a lot of dust and pet dander in particular. And so then these are always there. If you cannot avoid having carpet, then try to vacuum your carpet as often as possible to keep these dust away. So those are some of the basic things that you can do to avoid these big exacerbations in your asthma. But really the hallmark for treating asthma of any stage. So I don't think Dr. Pimpin mentioned this very much, but there are different stages of asthma, and people have, for lack of a better term, different grades of asthma. So some people can have very mild intermittent asthma that only comes on when they get a trigger. So those triggers could be infections. And so, so you have a friend who everybody gets a cold, everybody's over it in 2 or 3 days, but then 3 weeks later are still coughing, and they probably have mild intermittent asthma. And they can get away with not having a maintenance inhaler all the time, because for the most part, they only get sick when they get a trigger. But most asthmatics have persistent asthma, which need to have a maintenance medication all the time. So with an asthmatic who has persistent asthma, then the hallmark of treatment would be a steroid to keep the bronchial tubes from swelling up to begin with. Steroids are almost the best anti-inflammatory that we have, and so you need a steroid. What we don't want is for you to take what we call systemic steroids, so steroids by mouth or steroids in IV or IM form, because steroids have a lot of side effects that we don't want. But we do want you to take a steroid inhaler, because for the most part, these steroids go to your lungs and then they stay there where they need to work, and then they don't give you any of the systemic side effects. So there's a lot of different steroid inhalers. I mean, some of the most common ones would be Advair, Symbicort, and Breo. And these are actually combination steroid inhalers with other medications that help to open up your bronchial tube. When you are on a steroid inhaler, it's important that you rinse out your mouth every time you use it, because they can set up oral thrush, which is very uncomfortable. And so, depending on which steroid inhaler you have, you would have to use it either once a day or twice a day. And, it's better to use it as prescribed. So if you have a once a day medication, use it every day around the same time of the day, so that you can keep that level in your system pretty consistent. And then, we have the rescue inhalers, which are typically for most asthmatics would be albuterol. And basically what albuterol does is to help open up your bronchial tube, but it doesn't really tackle the problem of having airway inflammation, which is that swelling that Dr. Pimpin was talking about. So it would help you feel better, but they're very short acting and they don't tackle the underlying problem. So too many asthmatics rely on their rescue inhaler when they should be relying on a maintenance inhaler to keep them from getting into trouble to begin with. And then you have the rescue inhaler to keep you going all the time. And like I said, it's really important to try to prevent these triggers. So getting, most of my patients have to have a flu shot every year, because I don't want you to get the flu. You're going to be sicker with it than everybody else. Having a pneumonia shot, because prevention always is better than getting into trouble and then trying to rescue you out of it. Now, if you do get into trouble and you're using your rescue inhaler and it's not working, then at that point we would give you a systemic steroid to try to calm down that inflammation and get you out of trouble. And then you would go back to doing your maintenance medication.
Right. Thank you, Dr. Bruce. I want to say hello to Sir Crosby for joining in. I can see you, Sir Crosby, so it's really lovely to see you. Dr. Bruce, so my question to you is, well, in the UK, I know people die from asthma all the time, but there's this particular incidence of a 9-year-old girl who died in 2013 as a result of asthma complication. Now, my question is, why do some people die from asthma, from asthmatic attack? And then secondly, what are the complications? So other than death, which is the extreme, what are other complications that we could experience as a result of asthma?
So fortunately, like Dr. Pimpin hinted before, asthma deaths are actually uncommon, especially in the developed countries. Asthma deaths are actually uncommon, but some patients are, genetically or environmentally predisposed to having more severe asthma than others. And then unfortunately, some people are in an area where the triggers for their asthma are always around. So for example, if you're allergic to grass and grass is always around, then you have a constant inflammation. And if you're not able to get on top of that inflammation, then you can have pretty severe airway constriction. Now, when you have that airway constriction, it's really difficult to get air out of your lungs. And when you can't get the air out of your lungs and you keep trying to take a breath, you end up with what we call hyperinflation. And then your lungs are just really big blown out balloons that, you just can't breathe. And at that point, then you're not getting oxygen into your blood. So that can happen, but that is a really, really late stage of asthma. And it really, with all the treatments that we have, it's very uncommon for people to get there. So death is obviously one of the big complications, but in most places, that's a very uncommon complication. The more common complication of asthma is lost school days or lost work days, and that may seem like, no, that's not that big a deal. But if you have a child that's missing school and they're not getting the education that they need, then obviously that's a big deal. And especially if their asthma is really not controlled and they're spending, half the school year in the nurse's office or at home or in the hospital. Also, like ER visits and hospitalizations, unscheduled ER visits and hospitalizations are also complications of untreated asthma. So, we don't want patients in the hospital for the most part. We want you to be at home living your regular life. So being in the hospital because of asthma is a pretty bad outcome. In untreated asthma, if asthma goes untreated for a very long time, and that can happen, especially in people who have mild forms of asthma, they just get used to not breathing and they think it's normal until they get tested. And so when that goes on for a really long time, you can actually end up getting what we call fixed airway disease, where that swelling is constant and it doesn't actually narrow down, open up that much anymore. And then that can be, can lead to other complications, because now you start getting into areas of scarring and looking more like a COPD patient, even though you started off with asthma. So untreated asthma can have some of these complications.
Okay, so just whilst you're on that, is it true that some people can outgrow their asthma? Like, sometimes you hear people who say they used to be asthmatic when they were younger.
Right. So we have actually seen that sometimes in young adults, especially somewhere after the age of 18, where if they had really good treated asthma, that they can have no symptoms for a few years. Unfortunately, in a subset of these patients, they do get the symptoms come back somewhere in their 40s.
Okay, thank you so much. So I think we'll switch gears. So Dr. Pippin, we've been mentioning COPD. What is COPD? I mean, what has that got to do with the lungs?
Okay, so COPD is actually also another lung disease that affects the breathing tubes. But the main difference between something like COPD and asthma is that asthma tends to be reversible. It tends to be, if you give medicines, you avoid the stimuli, you avoid the things that bring on your asthma, you can keep your asthma in check pretty much, and nobody would even know that you have asthma until you have an attack. COPD, on the other hand, is a progressive disease. So because smoking is the main cause of COPD, your tubes are permanently damaged, and no amount of medicine can make those tubes any better. And so it gets worse over time. It tends to be present in older individuals who smoke, and their symptoms typically don't improve. Maybe they could be stabilized, but typically they just get worse over time. So COPD is the same swelling of the breathing tubes, but that swelling is permanent because it's scarring, and the narrowing is more permanent. And so they tend to be short of breath and more short of breath over time, as opposed to asthma, where when the trigger happens, you get short of breath, but you can reverse it more easily.
Right, thank you. So could we just briefly talk about the causes, and then let's start talking about the treatment? I was going to ask you for the full meaning of COPD, but it looks like someone has helped us already with that.
Oh, okay. So chronic obstructive pulmonary disease. Typically, we call it, or the two big diseases in there are emphysema and something called chronic bronchitis. So chronic bronchitis is coughing, bringing up phlegm, really getting short of breath quite frequently. And then emphysema is the air sacs and the supporting tissue that hold the air sacs together is what is destroyed. So the tubes are more destroyed in chronic bronchitis, and then the air sacs and the supporting tissue is what is destroyed in emphysema. But these days, we don't refer to those descriptors because most patients who have COPD have some element of both. And so it doesn't really help us in terms of treatment and otherwise to still be using the terms chronic bronchitis and emphysema. Most COPD patients have both. In terms of the causes, the main cause of COPD is cigarette smoking. 90% of COPDs have some history of cigarette smoking. That's in developed countries. In developing countries, we have the biomass fuels that cause exposure to wood smoke, charcoal smoke, all of those things that come from burning of wood, and that is presumed to be the most common cause worldwide, especially in places where people don't smoke as much. So it's outdoor pollutants, biomass fuels, and then for developed countries, it's cigarette smoking. However, there are many other triggers of COPD or causes of COPD. So indoor secondhand smoke. So some of the same themes that we've talked about can cause COPD in non-smokers. And then there are certain occupations, and there's a whole range of occupations. The problem with that assumption is that many of those occupations tend to lend themselves to cigarette smoking. So we're not sure if it's from the cigarette smoking or it's from the occupation itself. But people who work in construction, people who work in mining, people who work in industries where there's a fairly significant smoking exposure to begin with tend to be the same ones who also have COPD. So those are the big ones, smoking and biomass fuels. The treatment is fairly similar to asthma, but this time we focus mainly on medicines that relax the muscles around the breathing tubes. Those medications are called bronchodilators. And essentially, once you relax those muscles, the hope is that you get more air moving in and out. Some COPDs have an element of inflammation, and so they can be helped if you use inhaled steroids. And so the two big groups of drugs are going to be your bronchodilators, or the ones that cause relaxation of your breathing tubes, and then inhaled steroids that quieten any inflammation that the COPD patients may have. There's a whole host of other drugs that are out there that serve similar purposes. The goal is to open up the breathing tubes, make it a little easier for you to breathe.
Right, fantastic. Now let's move on very briefly because we are almost out of time. So, could you just talk us briefly through pneumonia? What is pneumonia? And then, secondly, is pneumonia really common around the cold weather? So, when it's like around autumn, winter, is that the time that most people experience pneumonia?
Yes, so pneumonia is, everybody throws that word around a lot, and it just means an infection in the lung. And so you can have any type of pneumonia, any type of infection in the lung. We can get viral pneumonias, which, we're in the COVID pandemic, so everybody is heard of COVID pneumonia. So basically any infection that actually involves the lung tissue itself is a pneumonia. Like I said, you can have viral pneumonias. Most common, though, we have bacterial pneumonias, and then you can have fungal pneumonias as well. And the hallmark of treatment of pneumonia is to be able to treat whichever organism is causing the pneumonia. So if it's a bacterial pneumonia, then you would use an antibiotic. If it's a viral pneumonia, then you would try to use an antiviral. Unfortunately, antivirals in pneumonia don't usually work. But then if you have a fungal pneumonia, you would use an antifungal. Pneumonia is more common in the winter months, and the answer is yes. Partly because cold air actually does sensitize you to more infections because of the changes in your airway. Cold air is usually drier, so it actually makes your airways more dry, and the cells are just more prone to being infected. But also, we're also more indoor, and so we're all aggregated more, and we can transmit these infections more. So it's not just the cold air, but it's also because we're always indoors and always together. That makes you more prone to pneumonias in the winter months.
Right. Now, on to my favorite question, Prof. Lai. Please, could you do me the honors? Let me ask this question. So growing up, my mom would always say, could you turn off the fan before you go to bed? Because if no, you're going to end up with pneumonia. And again, she would say to you, why are you walking around barefooted? You're going to end up with pneumonia. Now, how true is that? If you walk in the rain, if you walk around barefooted, if you sleep with the fan constantly on, are you really going to end up with pneumonia?
So like I said, getting cold will dispose you to pneumonia, but the fan will not, and the walking barefooted will not, but cold air will. So, I mean, if it was cold and then you are blowing that air, then maybe, but just having the fan on by itself, or even sleeping with the AC by itself, will not prone you to pneumonia. But yeah, not walking barefooted. I'm not quite sure how that pathophysiology of that is working out.
Okay, so we'll kind of move on and talk about TB. Dr. Pippin, actually, what is TB and what causes it?
Okay.
That I'm sure everyone who's listening has heard of TB.
Yes.
Before
Yes.
tuberculosis.
All right. So tuberculosis is caused by a germ that is typically inhaled, and it tends to cause lung disease in most patients. So 85% of people who get TB typically have what we call pulmonary or lung tuberculosis, but 15% can have TB in the brain, in the spine, in the kidney, and in essentially any other part of the body. I must also comment on the fact that it's probably one of the oldest diseases and probably one of the first diseases commented on in religious circles or in biblical times, pieces. And so it's a very old disease. And typically, anyone can acquire it, but typically it's people whose defense mechanisms are weakened and they are unable to fight the germ once they get exposed to it. Even in those who get the exposed to it, most people don't develop active infection. They have something we call latent disease. The TB bacteria doesn't grow, it doesn't do anything. And then over time, as your immune system gets weaker or you can't fight infections, the TB may re-emerge and become active at that point in time.
Right. So how common is TB then, Dr. Pippin? How common is it?
So the statistic is 1/3. Every 1 in 3 human beings on this earth is infected with TB. And it may seem like an exaggerated statistic, but this is exactly what I described before. Not everybody who has TB knows it because they don't have symptoms till their immunity gets weak, and then they actually maybe fall sick and get symptoms from their TB. Most people who have it are not even aware that they are infected. Infected doesn't mean you have TB disease. It just means that you've been exposed, you're carrying it around, but you have no symptoms from what you've been exposed to. So the biggest areas in the world with TB include India, China, Russia, Sub-Saharan Africa, so most of Africa. And those are the 4 big areas where TB is the greatest. One group of people that has suffered a lot more with TB is patients with HIV, because their immune systems are weaker. And every year in the world, we get about 10 million new cases of TB. Out of that number, about 2 million deaths occur from TB. And out of the deaths that occur from TB, almost 400,000 of those deaths are in individuals who have HIV. So that's the group that has been hardest hit with respect to TB and the emergence of TB in patients who have HIV disease.
Okay, so it sounds like TB is a different disease than the bacterial pneumonia that Dr. McBruce was talking about, right? Can you talk about the symptoms of it and how it is treated?
Okay, so like I said, people who have TB infection may have no disease, or no symptoms. And the reason why we know they have TB infection is because we do a skin test that turns positive, which means that you've been exposed to it at some point in time, but you don't have symptoms from the disease. When you have true TB disease, because the lungs are involved 85% of the time, you will have some lung symptoms like coughing, especially coughing up sometimes blood, but coughing, shortness of breath. But then because TB tends to cause a lot of what we call systemic symptoms, you lose your appetite, okay? You have weight loss, you have fever, you have night sweats. Those are some of the things that could show up in someone who has TB. But the main area that we focus on is the people who cough and bring up phlegm and sometimes blood-tinged phlegm. But TB can affect any other part of the body and cause symptoms.
Yeah, how about the treatment? Do you
Okay,
want to talk about the treatment?
so the treatment is we have several drugs. In fact, a total of 10 FDA-approved drugs for the treatment of TB. 4 of them are pretty much the mainstays of treatment. They are rifampin, isoniazid,
Ethambutol,
and pyrazinamide. Those are the 4 main TB drugs. And typically the treatment for TB is at least 9 months, 6 to 9 months. And the reason why the treatment needs to be given for so long is because the bacteria that causes TB can only be killed by the antibiotics when they are actively dividing. If the cell is not actively dividing or the bacteria is not dividing or growing, then the antibiotics don't work. And TB tends to be one of those things that tends to have dormant periods where it's not dividing. So you have to give the treatment for that long a period to make sure you get all of these actively dividing cells, which takes time. It doesn't happen over a short period of time. So unlike a bacterial pneumonia that you can treat for 1 week, this TB germ can divide for a period of 9 months. And so you have to stay on top of that division by giving the antibiotics for as long as we typically give it to them. And the problem is if you give it for shorter periods or they don't complete their treatment, the germ can become resistant to that same antibiotic. And the next time you give that same antibiotic, it won't work. And that's how we end up with all these multi-resistant or multi-drug resistant TB and drug-resistant TB.
So let me ask you this question. I know that at least most people in developing countries are given TB vaccination at birth. And so why is it that still we are having 10 million cases a year and 2 million people dying? Is it that the immunization kind of wanes with time?
Yes.
And also, so you say you take these treatments for 9 months. So that means you're taking these 4 antibiotics probably a few times a day for 9 months continuous.
So to answer the first question, typically your BCG or inoculation, as we used to call it, the scarring, wanes over time. And so by the time you are an adult, you depending on your circumstances, if you get exposed to someone who has TB, by the way, and that exposure has to be for a long period of time, okay? The minimum, the definition that is used is you need to be exposed to someone for at least 15 hours a week. That's the definition of a close contact. That's how you can get it, possibly from someone who has lung TB, who is coughing, singing, or talking. You can get it any of those ways, okay? So it needs close contact. It's not one of those where you spend a few hours with someone and you catch TB from him. Not to say that you should, but the point is it takes a lot longer exposure to develop TB when you're exposed to someone who has TB disease, not TB infection. You can't be infected by someone who does not. have TB disease. TB infection is your germ is sitting quietly in you. It's not doing anything. It's not bothering you. You can't spread it to somebody else. Only if you have lung disease or what we call cavities, holes in your lung, where the TB is sitting, so that when you cough, you can bring those germs out and they can stay suspended in the air for a little longer, but you have to be in contact with that individual for a fairly long period of time in order to catch it. So answer to the first question, it wanes, your immunity wanes. And 2, it's actually a very difficult disease to catch. And 3, you have to have decreased immunity, meaning if you're able to defend yourself, you're healthy, you're still less likely to catch TB, even if you are exposed to someone who has TB.
Right. So I've got a question for you again about vaccination. So my point is, like you're saying, you need to be exposed to someone who has the disease for long periods of time for you to actually catch it. So why then do children of African descent, why then are they made to have the vaccine when they are not born? So let's say when they are born outside their original home country, why then should they still have the vaccine?
Vaccine back home or in the new country where
in the new country.
So the thing is with TB, the exposure, like I said from the beginning, is highest in developing countries. And there are many people who are walking around with TB infection. They're carrying the germ around, they're doing okay, no disease. The only way we know that is we do a skin test or a blood test that says you have been exposed to TB before. Other than that, we don't even know that. The problem is when they do develop a weakened immunity, that puts them at risk, at higher risk than people who were not born in that environment. And that's part of why it is something that is looked at in terms of before you go into a school environment or work environment, you get tested. We all know you have TB infection, and then we can give you medicines, 2 medicines, typically one or both medicines for 6 months to kill any kind of TB germ or to at least reduce your chances of catching real TB when your immune system doesn't work. So you kill the germ in advance of you getting a weak immune system and possibly leading to you actually acquiring TB disease, which is where you have symptoms, weight loss, fever, night sweats, etc. But prior to that, you have a chance to identify whether you've been infected but not symptomatic, and you can be treated to decrease your chances of developing active TB disease later on in life when your immune system is decreased. But even things like diabetes or chronic kidney disease, any of those things can weaken your immune system and give you active TB. But if you've been treated when it's detected, then even when you develop those diseases, you're much less likely to develop problems of active TB.
Right. Fantastic. Thank you. So just before we round off, since I'm with a lungs expert, I'm just wondering, is there a way I could, in quotes, exercise my lungs, keep it healthy? What do I have to do, Dr. Bruce, to make sure that my lungs are healthy?
So you've actually hit the nail right on the head. Exercise. Lungs are probably the most conditionable part of your body. Like you can actually exercise your way into better lungs. So even if you have an underlying lung disease like asthma or COPD, the more you exercise, the better you do. Obviously, air quality is a big factor in lung disease. So trying to maintain a good air quality, like you can't change the environment that you live in, but you can change, like, for example, your home and have better air quality in the house. And, you know, a lot of times when people mention exercise, then we're thinking of running marathons and stuff like that. That's not what you need to be able to have good lungs. So being able to go for a 30-minute walk a day, and you have to walk at a pace where you're uncomfortable, but not where you're panting and gasping for air. But being able to do just 30 minutes a day for at least 5 days a week is enough to keep your lungs healthy.
I guess the other thing is to stop smoking or not smoke, right?
Don't
Yes,
start.
yes.
Don't start. It's really hard to stop, so
Yeah.
don't start.
So, Dr. Pippin, maybe the last question. Let's say somebody here listening to us is a smoker. They are addicted to smoke. And are there some strategies to help them to quit smoking?
Yes. So the quick one is that, as Dr. Daphne said, it's very difficult to quit once you start. So don't start. But if you already smoke, there are certainly things that you can do to help you quit. Here in the US, there's lots and lots of smoking cessation tools that include things like gum, patches, lozenges, inhalers of nicotine. All of these things can be used to help people stop smoking. But when I talk to my patients, I say to them, it starts with you. Okay? You absolutely have to convince yourself that it is time to stop smoking. So these are the things that I tell them. I say, write the top 3 reasons why you should stop smoking. Okay? Start with that. Do you want to improve your health? Do you want to lower the risk of catching a disease? Do you want to get rid of the lingering smell of tobacco smoke around you all the time? Do you want to stop exposing your children and other family members to secondhand smoke? Do you want to save money? Because you can save a lot if you stop smoking. I give them all of those things, and it's like, check, 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 doc, all 5. So I say then, let's come up with a plan. That's the next stage. So first stage is tell yourself all the reasons why you want to stop. Once you convince yourself you have more than 2 reasons, start working on a plan. And many of them will tell you, oh, doc, I've tried this, I've tried that, and nothing seems to work. Don't try the same thing more than twice. Try something else. If you tried quitting cold turkey, try quitting a little at a time. Don't try cold turkey twice and then give up, because that's not going to work. It doesn't seem to suit your particular way of stopping smoking. And then the last one I tell them is, you know what? Keep a list of how much money you save from not smoking, if you manage to get to that point. And then once you've built up your bank, treat yourself with something nice. And when they see that they can do something significant with the money they've saved, they suddenly start looking for ways to cut back and eventually stop smoking. It is not an easy thing. I tell them, on average, it takes 7 attempts before people successfully quit smoking. So if they come to me and they say, oh, I'm on attempt 4, I tell them, oh, you know what? You have maybe 3 or 4 more. Okay? You still have many more opportunities, because the average patient doesn't stop smoking until 7 attempts have been made. And when they get to the 7th attempt, I tell them, you know what? You may not be the average patient. You may need 8, 9, or 10 more attempts before you stop. And I see a question about the majority of TB patients are HIV positive. So depending on the part of the world, that may be true. It's not unique to all parts of the world. And I would say sub-Saharan Africa, unfortunately, many of the HIV positive patients tend to be, or many of the TB patients also tend to be HIV positive. And the HIV positivity is what unearthed their immune system, the weak immune system, and caused them to develop active TB. So they may have been walking around for years, not HIV positive, but still had TB infection, meaning they had been exposed somewhere. Once the HIV comes in, your ability to fight TB goes down, and then you develop active TB and start coughing, fever, night sweats, all that stuff.
Thank you very much. And Dr. McBruce, do you have any message, a take-home message that you would like to pass on to our viewers, please?
So like we've already said a lot, smoking is bad. I mean, there's not much more take home than that. Almost every lung disease is related to cigarette smoking, and cigarette smoking makes it worse. And if you have never started smoking, don't start. But if you're already a smoker, there is always help to quit smoking. There's a lot of foundations that have, even if you like need patches for free, or if you need like a smoking cessation program, there's a lot of places. Like in Arkansas, it's a really simple number. It's like 1-800 quit now, and I don't know about other parts of the country, but there's a lot of programs to help you quit smoking. So just, it's hard to ask for help, but ask for help. And then the other thing is, don't take shortness of breath or cough lightly. Too many people say, oh, I think it's just old age, and then, you're only 40, you can't walk from here to the mailbox, and you think, oh, it's because I'm aging. No, it's not because you're aging. Shortness of breath is not normal. Even though your lung function declines with age, you don't feel short of breath unless there's actually something wrong. So if you are having symptoms, shortness of breath, cough, wheezing, chest tightness, take it seriously, get some help. Don't go untreated for long periods of time, thinking that it's just because you're getting older.
Brilliant, thank you. So, like in the UK, I know in the month of October, there's actually an annual campaign to stop smoking. And yeah, I know people patronize it. Now, Prof. Lai, I'm coming to you at this point. So we are a Christian organization. So like Dr. McBruce said, maybe someone is secretly smoking. They really want to quit. Dr. Pippin has given us some practical things. Like, I like the way he said it. Find at least 2 reasons. What would you say, Dr. Lai, now tackling both the medical and the spiritual side of things? How can we help in case someone is watching? There's this young person who is in this cycle of they quit for 3 months, they go back to 8, and then they quit for 2 months, and then they. What would we say to them at this point as we end the show?
I think, what I would say is don't give up. Okay. And for those who don't smoke, we have to understand that addiction is a very powerful thing. And it's not just with smoking. I mean, with other hard drugs. Okay. Addiction is a very powerful thing. It's almost like a possession. Those of you who would understand it, like a demon possession. I mean, it's like being in shackles. So, and that's why it's difficult for people to individually try to quit. And I like the fact that Dr. Pippin said, if they come on their 4th try, he says, you still have more to go. Even if they hit 7, which is the average, maybe you are not an average person. They need help. And so I think the issue is any form of addiction. It doesn't have to be just, cigarette smoking addiction, but any form of addiction. The first thing that you have to understand is that you have to understand that this is an addiction. Because if you don't accept that fact, you're not going to seek help. A lot of times when you talk to smokers, they just brush it off. Oh, I can quit when I want, unless and until you accept the fact that this is an addiction, and for you to break an addiction, you need help. Fortunately for those living in developed countries, there are a lot of help. There's a lot of help. Dr. McBruce mentioned like one here in Arkansas, which is an easy number to call. In some places, you don't have that, all those resources. But again, once you identify that you have an addiction, then you can seek help. And sometimes it may be an accountability partner, even if you don't have all the resources, someone that can hold you accountable to make sure that you quit. And sometimes, I mean, there have been instances where a spouse, somebody would say they quit smoking because their wife put their foot down and said, you are not smoking anymore. and took away their, their cigarettes from them. And so having an accountability partner can also be helpful. And obviously, as I said, smoking is an addiction, and so there's the power of prayer as well. Putting all these things together will help people to stop. And for those of us who don't smoke, if somebody kind of stops and then goes back to it, let's support the person and let's help them through the difficulties that make them go back, to the smoking, rather than to stigmatize them and to think that, oh, this person doesn't want to change. It's not that they don't want to change, it's an addiction, and it's a stronghold, and it needs to be broken off of them. So that's what I would say.
Brilliant. Thank you so much for that. I think that's just the right icing we needed on top of our cake. And on that note, we've come to the end of tonight's session of Time with the Doctors looking at the lung diseases. I want to say a very big thank you to Dr. James Pippin and Dr. Daphne McBruce for joining us tonight. It's always a privilege to have you doctors with us. And the truth is, you don't know how much of a big difference you've made tonight by sacrificing your 2 hours with us. We have people watching from Kenya, we have people watching from Zambia, people, UK, people in Ghana, people in South Africa, people in Monrovia, Liberia. So you've made such a big difference just by saying yes to us tonight. And we just want to bless you so much for that. We've come to the end of tonight's session. Now, next week, I think for the next 3 weeks, actually, so they'll be looking at Wisdom Conference, will be looking at a very interesting topic, which is some mistakes of young ministers. I hope I'm right, Samuel. Some mistakes of young ministers. And it's going to be a 3-week series. So please do join us. You don't want to miss it. It's going to be so educative and so insightful. Thank you so much for joining us again. And God bless you. Thank you, Prof. Lai, once again for making this happen. Thank you.
All right.